Thank you so much. All right, we'll make a start. Hello, everybody. I'm Lee Bell. I'm President of Cardiomyopathy Australia, New Zealand. A warm welcome and kia ora to you wherever you're joining us from here in Australia, New Zealand, and around the world. You're welcome to this Meet the Experts webinar on hypertrophic cardiomyopathy, which we're hosting in conjunction with the Ingles Lab at the Garvin Institute of Medical Research, being recorded on the 18th of August 2026. We acknowledge the traditional owners of the lands wherever you're joining us from, and you are very welcome. So we've got three fantastic speakers for today's sessions, and I'll introduce those in just a moment, along with the topics. But just by way of introduction, I'm a fellow HCMer myself, diagnosed as a young child. I've received a variety of the therapies, including a myectomy in my teens. I've had 5 ICDs, atrial fibrillation, ablations, cardioversions, and then end stage HCM, for which we need a different term, end stage burnt out. And I received my precious new heart 5 years ago this month. So I'm post-transplant. So I'm one of the very tiny percent that progressed to transplant. Only about 2 to 3%, I think, is the numbers. So I understand from that experience that living with HCM can be a bumpy road and a rough road, but it doesn't need to be a lonely road or a road without enough information. So that's why I'm here at Cardiomyopathy Australia, New Zealand, working with my gifted years to try and improve support, information, advocacy, and awareness for our big-hearted community. So that's me. We can't do what we do here at Cardiomyopathy Australia, New Zealand without the support of the clinical community, and that support has been deep and broad and generous. And today's an example of that. So sincere thanks to Andris, Ellims, Vimal, Patel, and Jodie Ingles for being here with us today. So I'd like to tell you about our speakers, tell you what topics they'll be covering, and then hand over. Our first speaker is Dr. Andris Ellims, a cardiologist and cardiac imaging specialist based in Melbourne. Andris is director of the HCM clinic at the Alfred Hospital, which he established as Victoria's first dedicated clinic for hypertrophic cardiomyopathy. He'll be talking us through the different types of HCM, the symptoms, how it's assessed and managed, as well as newer therapies like mavacamten and guidance around exercise and competitive sport. Then we'll have Dr. Vimal Patel, a cardiologist from Perth with a special interest in cardiomyopathy. Vimal completed subspecialty fellowships in cardiac devices, advanced heart failure, and in cardiac transplantation. Vimal will be speaking with us about risk stratification, ICDs and the different types available, and complications such as arrhythmias and heart failure and other considerations. And finally, Associate Professor Jodie Ingles, a cardiac genetic counsellor and researcher with more than 25 years experience working with families affected by inherited heart disease. Jodie's head of the Ingles Laboratory and director of the Genomic and Inherited Diseases Program at the Garvin Institute of Medical Research, and continues to see patients and families at Royal Prince Alfred Hospital and Macquarie Cardiology. And she'll be covering the genetic architecture of HCM, genetic testing, family screening, and what's on the horizon for potential future genetic therapies. So a quick comment, we invited pre-submitted questions, and a number of these will be answered with the answers woven into the speakers' talks, but we had nearly 100 people register and so many great questions that we won't have a chance to get to all of them today. So if at the end we don't get time for all the questions, or we don't get time for a question and answer session, you'll receive a feedback form with the recording at the end of this session. And if you can put any burning questions in there, any general questions, and we'll endeavour to come up with another forum or another way to make sure that your questions can be answered. So apologies in advance if they're not answered in this session. Next slide, please, Laura. So some general notes. This webinar contains general information and shouldn't replace information and advice about your specific HCM from your own healthcare team. We're recording and we'll be sending out, posting online. So we've turned off cameras and microphones for attendees. We think we have. If we haven't, if you can please turn yours off, that would be appreciated. And we have received some grants from Pfizer and Bristol Myers Squibb to develop educational content, and we acknowledge them and we are grateful for their support. So now it's my pleasure to hand over to Andris to talk to us about the different types of HCM symptoms, how it's assessed and managed, and some of the newer therapies and some guidance around exercise. Thanks very much, Andris.
Great. Thanks, Lee, and thanks for the invitation to be involved in this exciting webinar. It's great to be speaking to so many people from across Australia and New Zealand this afternoon. Next slide. Thanks, Laura. So just a little bit of background. Hypertrophic cardiomyopathy really is defined by the presence of otherwise unexplained LV hypertrophy, and it really does have a genetic basis that Jodie will speak about in more detail later. Prevalence is reported at different degrees depending on what you read, but roughly 1 in 400 in the general population. It is the most common inherited cardiovascular disease, and inheritance is autosomal dominant. So again, Jodie will probably touch on that in her talk. Next slide, please. I thought I'd start with an MRI on the left of a normal heart, and this is an MRI of one of my patients with HCM on the right. I don't have a pointer, but we look at the left ventricle, which is a horseshoe-shaped muscular structure beating away nicely on the left. The normal thickness is up to about 11 millimeters, fairly uniformly around the left ventricular wall. On the right side, we've got a patient with quite significant HCM, and this patient's septal thickness is around 35 millimeters. And we'll talk about the role of MRI along the way, but just a nice way to show an example of a normal heart and then an HCM heart. Next slide. Not only macroscopically is the heart abnormal with HCM, but also when we look under the microscope, we can see abnormal cellular structure. So on the left, normal myocardium with a nice muscle cells lined up in a nice parallel manner. And then an example of a patient who had a septal myectomy, so surgical excision of part of the left ventricular wall, showing quite disorganized appearance to the myocytes. And between those cells, also some connective tissue or fibrosis, which we see with this condition. Next slide, thanks. The genetic basis of HCM involves several potential genes. Next slide, please. A couple of the main genes that Jodie will mention involve beta-myosin heavy chain and myosin binding protein C. It's important to be aware that someone with HCM, a fairly definitive diagnosis of HCM, when we do genetic testing on patients, we don't always find a pathogenic mutation. It doesn't mean that there's not a genetic basis to this condition. So there are challenges with genetic testing, which Jodie will talk about later. Next slide, thanks. I wanted to put this slide up early because since I've been looking after patients with HCM, patients come to me saying they've got HOCM. It's not a term that we always interchangeably use with HCM because only 2/3 of patients with HCM actually have some form of obstruction. When we're talking about obstruction, we're talking about whether there's challenges with blood physically leaving the heart. And if we look at populations of HCM patients, about 1/3 of patients will not have any obstruction to blood leaving the heart, either at rest or with provocation. And by provocation, I mean either the Valsalva maneuver, which is or should be done when patients with HCM have a standard echocardiogram, or provocation with exercise. So that's something that can only be picked up during a stress echocardiogram, for example. So the data tells us that roughly 2/3 of patients with HCM do have obstruction or obstructive HCM, but not always at rest. Sometimes provocation is needed. Next slide, please. When it comes to symptoms, very, very variable clinical presentations. Many of my patients are asymptomatic, so they've had a family member with HCM and they've been screened and found to have the condition. Sometimes a murmur can be auscultated during a physical examination. Sometimes a routine ECG can identify HCM. The commonest symptoms we see arising from HCM would be shortness of breath with exertion, and there's different mechanisms from that I might touch on in later slides. Chest pain is an interesting symptom, can be with exertion. I've got many patients who have chest pain when they exert themselves after meals, and you don't really see that in the literature that much, but I've got probably 12 or 24 patients who describe that very unique symptom. The pattern or the reason people get chest pain with HCM can be varied. It can be due to outflow tract obstruction. It can be microvascular disease at a small vessel level. There's many potential mechanisms for that. Presyncope refers to dizziness. Syncope refers to loss of consciousness. and palpitations, because any arrhythmia is more common in HCM. Next slide, thanks. We talk about complications. So in addition to arrhythmias, and Lee touched on this, heart failure can occur, and there's also sudden cardiac death, but increasing research is telling us that the much quoted 1% annual mortality rate in this condition is much less, particularly when patients are well managed at HCM centres. Next slide, please. So I thought I'd start with just an example from an echocardiogram. Echocardiograms are pretty easy to do. There's no radiation involved, no needles, and really is a mainstay of diagnosing and then monitoring patients with HCM. This particular patient has thickening right in the middle of the image of their septum, roughly around 20 millimeters. The wobbly thing that you see opening and closing is the mitral valve letting blood in. In this particular patient, that mitral valve is getting drawn towards the thickened septum, and that's contributing to the mechanism of outflow tract obstruction. Blood then leaves the aortic valve, which is the door opening and closing in the top right part of that moving image. So echocardiograms are really essential in diagnosing and then monitoring this condition. Next slide, thanks. When we do echocardiograms, a good sonographer will take a lot of time trying to measure how hard it is for blood to leave the heart. And this requires a lot of expertise and patience. And these measurements should be done at rest, but they should also be done with Valsalva. So if you're someone who's got HCM having an echocardiogram, it really is only a complete test if the sonographer asks you to do a Valsalva maneuver. That might be clearing your ears. It might be tensing your tummy muscles. It's essentially holding a strain for a period of several seconds, because this can sometimes exacerbate or even provoke outflow tract obstruction. So that's an important thing to say. So that's the middle image, which is a pressure gradient of 77 millimeters of mercury. Normally, when blood is leaving the heart, it's less than 10 units of pressure. So that particular patient with the trace in the middle has got quite significant outflow tract obstruction. The graph or image on the right side of the screen is an example of incorrect measurements of obstruction. So if there's a leaky valve, the mitral valve, which is very close to blood, where blood leaves the heart, then it can be difficult, if the study is not done properly, to overestimate outflow tract obstruction. So if there's inconsistencies in your echocardiograms over the years, sometimes it can be due to technical factors as part of this echocardiograms. Important to have these studies done at an excellent centre. Next slide, please. So stress echocardiograms are echocardiograms where we add an exercise element to it. In the context of HCM, I often use stress echocardiograms at baseline and then infrequently along the way to document someone's exercise capacity on a standardized Bruce protocol. Also see whether we can provoke any arrhythmias. But most importantly, in our patients with HCM, see whether exercise can provoke outflow tract obstruction. And to do that, we need to get the images straight after exercise before the heart rate settles. And similar to the resting echocardiogram, it's important to do this at an experienced centre to get the right data. I've had many patients who've been referred to me who have had non-obstructive HCM as the label of their diagnosis, but then we've put them on a stress echocardiogram and we've been able to attribute symptoms to obstruction with provocation, and then that's enabled appropriate therapy. So that's the role of stress echocardiogram in the patients that I see. Next slide, please. One of the first slides I showed was of a cardiac MRI. So I'm fortunate at the Alfred Hospital to have ready access to cardiac MRIs. They're not covered by Medicare for patients with HCM, so often several $100s out of pocket. When do I use these tests? I often use these tests to confirm the diagnosis of HCM. We can sometimes have copies of HCM. There could be conditions such as cardiac amyloid that can be diagnosed via cardiac MRI. So when I'm unsure of a diagnosis of HCM, a cardiac MRI has a role. The cardiac MRI provides us with gold standard measurements of wall thickness. So when there's doubts or discrepancies on echocardiograms about true wall thickness, I use cardiac MRIs. And then on the right side of this image, you can see a couple of circled areas. So these bright areas correspond to areas of scarring or fibrosis of the muscle wall. And most patients with HCM will have some degree of scarring. And the presence of scarring can help diagnose this condition or diagnose copies or things that mimic HCM. And the amount of scarring, the more there is, that can increase the risk of sudden cardiac death and arrhythmias, which Vimal will talk about later. Next slide, please. So when we come to broad principles of management, I always go through these headlines with each of my patients. It's really important that we educate our patients about the condition, what it means, the mechanism potentially of their symptoms. And then once we've done that, I talk about lifestyle modification. I've always been very liberal when it comes to allowing my patients to not be restricted. Now, there'll be some patients who have significant exertion-related arrhythmias, significant or severe symptoms that we need to be a bit bespoke with their management. But by and large, I don't limit my patients with HCM from any physical activities. I don't limit them to particular heart rates. If they're professional athletes, that's a completely different discussion. It's something that we often have to talk to them in great detail about, often multiple occasions. But competitive athletes, because they're putting their body under extreme stressors and being under psychological stress as well, we generally dissuade professional athletes from participating in sports or certain sports if they've got this condition. But non-professional athletes with HCM, I generally don't restrict patients whatsoever. But different cardiologists will have different advice, but that's what I do. Next slide, please. There is increasing evidence over the years, and guidelines have been following the evidence as it's been mounting, that patients with HCM, by and large, can do unrestricted physical activity. This was from a major journal back in 2023, looking at a cohort of patients. Next slide, please. 1,660 patients from many centres, and looking what happened to those patients over several years, particularly in regards to whether patients passed away, whether they blacked out from arrhythmias, whether if they had devices, the devices activated. And they found that in patients who did vigorous intensity exercise versus non-vigorous intensity exercise, the outcomes or bad outcomes were identical. So the guidelines will follow this research along the way, but several questions about exercise. I don't restrict my patients unless they're professional athletes. Next slide, please. So then we go on to therapies, and if patients don't have symptoms, I don't put them on medications at all. We don't have any medications thus far that change the prognosis of HCM. So most of the things we'll talk about therapy-wise are about reducing symptoms. Next slide, please. Traditional medications, next slide, please, and next slide, please. Traditional medications for HCM have involved verapamil and beta blockers, and a lot of the symptoms arising from HCM do come from obstruction. And once we've confirmed the diagnosis of HCM and we've been able to document, perhaps on a stress echocardiogram or just even with questioning how symptomatic patients are, we can then talk about therapies. Next slide, please. The first thing I talk about is avoiding dehydration. Many patients with obstructive HCM and symptoms do worse in warmer environments or during the summer. When patients are dehydrated, the ventricle and the heart is underfilled, and that can exacerbate outflow tract obstruction. So merely improving hydration and salt intake during the warmer months can certainly help with symptoms. There are certain antihypertensive agents which cause enlargement or dilation of the vessels, and this can contribute to outflow tract related symptoms. And then there can be also other non-cardiac conditions which can aggravate things such as low hemoglobin, which need to be corrected as well. Next slide, please. I still use these traditional agents. I prefer verapamil to beta blockers because I find my patients usually tolerate it better in terms of fatigue and energy levels, but both are considered first-line agents when it comes to managing symptomatic HCM, whether it be obstructive or non-obstructive. And I generally do a trial for a couple of weeks, starting at a low dose and up titrate accordingly. Next slide, please. In the last couple of years, we've been very fortunate to have access to mavacamten. So this is an agent now available in Australia via the PBS. There are some stringent requirements, but I've got many patients now on this agent who are doing very well. There is another agent called aficamten that is not available in Australia yet. It has the advantages of having a shorter half-life, which practically means when we adjust the doses for this aficamten agent, it can be done more quickly than we do with mavacamten. And there's also less interactions with other medications. Mavacamten, we need to be mindful of agents that are metabolized by the liver. With aficamten, that can be done less so. In terms of the study data, there's also suggestion that aficamten may have a greater role in non-obstructive HCM. Unfortunately, the studies published thus far for mavacamten's role in non-obstructive HCM, we don't have any good data showing that there is a benefit. Aficamten, I don't know when that will be available in Australia, but if there is a time period, it would be months to years, but I'm not aware of any updates in that regard yet. Next slide, please. So how does mavacamten work? Well, what happens with HCM is it's often an overcontraction of the left ventricle, and that can exacerbate symptoms and cause outflow tract obstruction. Mavacamten is designed to reduce the excessive myosin-actin cross-bridging. So these are proteins in the muscle cells of the heart, and by doing so, normalize, that is, reduce the overcontraction of the left ventricle, along with some other effects as well. Next slide, please. I'm not going to go into great detail with the two major studies that supported the use of mavacamten, but this particular study called Explorer HCM looked at a cohort of patients on mavacamten versus placebo for 30 weeks. And in the group that were on mavacamten, they had subjective and objective improvements in exercise capacity over that 30-week program. Next slide, please. In this study called Valor, patients who were planned to have more aggressive treatments for obstructive HCM, namely surgical myectomy or alcohol ablation, which I'll touch on later, they were randomized to either receive mavacamten or placebo for 16 weeks. And at the 16-week period, out of those patients, only 18% still were candidates for either myectomy or alcohol ablation in the mavacamten group. So this has revolutionized the way we manage patients with symptomatic obstructive HCM. I should say that mavacamten needs to continue for the effect to continue, and we'll go to the next slide. I also want to put in septal reduction therapy. So in Melbourne, myectomy is the preferred septal reduction therapy. Whichever procedure is done, it needs to be done at a centre where many of these procedures are done. Unfortunately and fortunately, with the advent of mavacamten, we're seeing a dramatic reduction in referrals for both myectomy and alcohol ablation, which means that the surgeons who are experienced and the procedurists who are experienced at this are doing less cases. So this is one of the negative outcomes of having mavacamten available to us. Next slide. This is a simplistic diagram as to what happens with septal myectomies. It is an open heart surgery procedure. The theory is to cut out the basal septum, so not the whole of the thickened heart muscle, to make it easier for blood to leave the heart. And this usually leads to fairly dramatic improvements in symptoms once patients have recovered from the surgery itself. Next slide, please. And another slide here just for alcohol ablation. Essentially, a controlled heart attack to cause scar tissue in the area that's thickened, and over time, that area thins out. But similar mortality rates across both procedures, even though the alcohol ablation procedure is less invasive. Next slide, please. Vimal will talk about defibrillators and family screening. Next slide, defibrillators, sorry, and Jodie will speak about family screening. So at this point, I'll hand over to Vimal, and I'm sure there'll be opportunities for questions later in the webinar. Thank you.
Thanks, Andris, for a great talk, and it's my pleasure to be here. And I thought I'd talk about risk assessment in hypertrophic cardiomyopathy. Next slide, please. So these are my disclosures. Next slide. So risk in hypertrophic cardiomyopathy is quite complex. So we often spend lots and lots of time talking about the risk of sudden cardiac death, but really we all know people that manage hypertrophic cardiomyopathy and manage it well know that it's far more complex. So we have to talk about the risk of atrial fibrillation, which is an irregular heart rhythm from the top of the heart, which is associated with stroke. We have to concern ourselves with the risk of developing heart failure over somebody's lifespan. People often require lots of work clearance, and there's a risk associated with people doing certain jobs. There's a psychological aspect of managing HCM. There's a risk associated with exercise in certain scenarios. And then obviously we talk about inheritance. So risk in HCM really is a complex entity. For the next slide, for the purpose of this talk, I'm going to focus on atrial fibrillation, heart failure, and sudden death, because those are the things that we probably spend more time talking about. Next slide. And next slide. So coming on to AF, AF is probably the most common arrhythmia in the Western world, and it's something that increases with age, even in patients with normal hearts. But what we do know is that we see a lot more of it in hypertrophic cardiomyopathy. And although the arrhythmia arises from the top of the heart, which is the area which is not affected by the thickening of the muscle, hypertrophic cardiomyopathy really is the perfect condition in which atrial fibrillation can develop. So due to a number of factors, whether that be genetic, whether that be some of the regurgitation from the leaky valve, whether that be because of increased pressures throughout the heart, what we know is that the top chambers of the heart tend to enlarge in patients with hypertrophic cardiomyopathy, and that increases the risk of developing atrial fibrillation. Next slide. And what the data will tell you is approximately about a quarter of our patients over their lifespan will develop atrial fibrillation with hypertrophic cardiomyopathy. Next slide. And the reason why this is important is that we all know that atrial fibrillation is associated with a much higher risk of stroke, and especially so in hypertrophic cardiomyopathy. And in patients with atrial fibrillation, approximately a quarter of those will go on to have a stroke if not managed appropriately. Next slide. So we often talk about the role of blood thinners or anticoagulation in patients with atrial fibrillation to try and minimize the risk of stroke. And the concept of that comes from the fact that when patients are in atrial fibrillation, the blood doesn't flow around the top chambers of the heart quite as nicely as we like, and there's scope for blood to sort of stagnate and form small clots. And therefore, having patients on blood thinners has been shown to be effective at reducing the risk of stroke. Now, blood thinners obviously come with their own risks, so we always have to do a risk-benefit ratio as to who's going to benefit and who's not. And typically with most cardiac conditions, we use a risk calculator, which is something called a CHADS2 VAS score, and that uses lots of other factors in terms of other comorbidities, age, gender, and a few other factors to try and delineate who's at high risk and who's at low risk. And certainly the higher the score gets, the higher your risk gets. But what we know with hypertrophic cardiomyopathy, that score is not valid. So anyone that has atrial fibrillation, even if their conventional stroke risk is considered low, that doesn't necessarily translate to a low risk in HCM. So certainly, next slide, please. The guidance will tell you that if you have atrial fibrillation with hypertrophic cardiomyopathy, you really should be anticoagulated with blood thinners. And there's several choices now. We have once daily drugs, twice daily drugs, and warfarin is also something that's used, but more commonly we're using what we call DOACs or NOACs, where you just take a tablet once or twice a day without needing to get regular blood tests. Next slide. As mentioned, we also see heart failure in our patients. And again, the data will show you that the younger you are at diagnosis, the higher your risk over your lifespan of developing heart failure is. And that could be either with the need of needing some advanced therapies like transplant or mechanical support, developing a weakened heart muscle. Often patients with hypertrophic cardiomyopathy, as Andris showed, often have very good cardiac function, but a small proportion of our patients may go on to develop a weakened heart muscle. And also patients can be quite riddled with symptoms, having severe functional limitations and getting quite a lot of exertional breathlessness. And certainly, as the data shows here, the younger you are at presentation, the longer you live with your disease, the more likely you are to develop some of these heart failure related issues. Next slide. And when we look at what the cause of heart failure in our patients are, we typically see two distinct patterns that cause heart failure. Next slide. So the first of these is where the heart muscle actually looks like it's working pretty well when it squeezes, but what happens is that it has problems with relaxation, and that's what we call a restrictive phenotype, where although the heart is pumping well, it's not relaxing well, and that increases the pressures going through the heart, causes an enlargement in the top chamber of the heart, which you can see on the bottom right of the screen. Sorry, upside down. That's how we echo. We're weird people. You can see that an increased pressure, dilatation of the heart chambers, and that's often associated with people then developing symptoms of fluid retention, breathlessness when they lie down at nighttime. And that's often associated with an increased risk of getting atrial fibrillation, like I spoke about a little bit earlier. And so typically what we see is that when we start seeing patients having symptoms, they'll get progressive deterioration in symptoms, which is often then unmasked or exacerbated by the development of atrial fibrillation. And at that stage, patients will often need cardioversions or undergo AF ablations. But generally, with a lot of patients with a restrictive physiology, they can get a progressive deterioration to a point where we need to consider some of the advanced therapies, including transplantation. Next slide. The next cause for patients getting heart failure is that about 5 to 10% of our patients will develop progressive cardiac muscle weakening. So as mentioned, the heart function is normally pretty good in patients with hypertrophic cardiomyopathy, but in about 5 to 10% of our patients, we do see over time the cardiac function starts to get impaired. Next slide. And this is an MRI of somebody with a weakened heart muscle, so it doesn't have that dynamic contraction that you saw when with the pictures that Andris showed. And this is usually paralleled by the development of really quite extensive scar in the muscle. So the muscle gets replaced with lots of fibrous tissue and scar, and overall the cardiac function starts to get impaired. Next slide. And this is important because from the onset of developing a weakened heart muscle to needing advanced therapies is often less than a decade. So when we start to notice that patients' cardiac function is starting to drop off, we really need to be aggressive in, firstly, how we manage them, how we change tact, and we often go from hypertrophic cardiomyopathy specific treatments to introducing more general heart failure types of treatment. And we need to sort of often refer these patients to centers where they start to see people that do advanced therapies and transplants at an earlier stage. And although it may not be needed for a lot of our patients, it's certainly better to be overcautious and get them seen by the right doctors as opposed to waiting till it's all a bit too late and doing things in a rush. What we also know is that once the heart muscle does start to weaken, the risk of getting dangerous arrhythmias also increases. So we need to be very cognizant of that. And in patients that don't have defibrillators, certainly the development of cardiac weakening or heart muscle weakening is a good indicator to suggest that we need to at least start having some discussions about the role of defibrillators. Next slide. So moving on to the risk of sudden cardiac death and the role of ICDs. So fortunately for us, what we know is that the absolute event rates of sudden cardiac death in our patients with hypertrophic cardiomyopathy remains low. So as you see, even in our younger patients, the absolute mortality rate is about 1%. And that obviously increases in age as it does with everything else and age-related causes of mortality. Next slide. But what is really important, and perhaps this is sort of a reminder to us all when we're seeing young patients, is that although the absolute mortality rate remains low, for patients that are young, certainly under the age of 40 and perhaps under the age of 30, their relative rates of experiencing an adverse outcome is about 15 to 20 times higher than their peers. So although that 1% may not seem like much, in the grand scheme of things, when they're compared to their peers, it is significant. Next slide. And when we look at what is the cause of our younger patients dying or our patients dying full stop, what we can certainly see is that in our younger patients, certainly those, as I mentioned, under the age of 40, sudden cardiac death or dangerous arrhythmias that originate from the bottom of the heart, the thickened chambers, certainly account for the majority of the causes of mortality. And then as you get older, the sort of the heart failure related mortality starts to increase, and then as you get into sort of the later decades of life, non-cardiac causes tends to start to take an increased majority or increased percentage. Next slide. And what we can see overall is that we've made some progress, and I think our overall mortality rates of people dying suddenly from this condition is reducing. But that's been in stark contrast. The amount of ICDs that we're using is also increased disproportionately. So there's maybe a slight discord. ICDs may have some benefit in reducing the risk of sudden death, but the amount we're using is certainly increased disproportionately. Next slide. And that sort of brings us on to the question, how do we risk stratify our patients with hypertrophic cardiomyopathy? Next slide. So historically, we used to use 5 conventional risk factors. So how thick your heart was, so certainly a thickness over 3 centimeters would be considered severe. If you'd ever blacked out, if you'd had an abnormal blood pressure response to exercise, if you'd had any short runs of heart rhythm disturbance from the bottom of the heart, or if there was a concerning family history. Next slide. The issue with this was that all of the risk markers were considered relative. They're relative and they're not an absolute risk, and all of them were treated in the same way, and they were considered binary and not continuous. So is it fair to say that somebody that's got a wall thickness of 28 millimeters is at higher risk than somebody that's got a wall thickness of 27 millimeters or 30 to 29? Probably not. And what we knew is that this probably using just individual risk markers to govern ICD decisions was probably overestimating risk and promoting us implanting devices. Next slide. So around about 2013, 2014, there was a risk calculator developed in Europe, which was a more kind of way of giving a can never say that word properly, a personalized risk. So we'd input some variables that were specific to the patient we were seeing, their age, how thick their heart was, how big the top chamber of their heart was, the gradient that Andris spoke about, whether there was a family history, whether they'd had an arrhythmia or they'd blacked out. And it gave us a personalized risk of what that person's risk was over the next 5 years. And we typically use a cutoff of less than 4% as being low risk, 4 to 6% as being an intermediate risk, and over 6% as being a high risk where we should definitely consider the role of a defibrillator. Next slide. The advantage of this was, as I spoke about, is it gave an individual I'll skip that. It will give them a specific risk to them. It was also far more accurate in predicting the risk of sudden arrhythmia. So we know that the model performed better than what the individual risk factors did. And it was probably the most validated way of assessing risk. So it was not only validated against a large internal cohort, it also had external validation. So more and more of us have switched to using a risk calculator to provide the patient with information that is based upon their sort of clinical features. Next slide. Andris spoke about the role of SCAR, and you saw that SCAR wasn't included in that risk factor. And we do have some data. So SCAR is something that is often synonymous with patients developing hypertrophic cardiomyopathy. So it's not unusual for us to see areas of SCAR in patients that have got hypertrophic cardiomyopathy when we send them for an MRI. There is some data to say that the more SCAR you have, the greater the risk that confers. And certainly, I think that's true for the risk of developing heart failure. So what we know is if somebody's got a lot of SCAR, we're definitely very vigilant for the risk, vigilant for the development of heart failure. But there is also some data to say that the more SCAR you have, the higher the risk of you experiencing a cardiac arrest or sudden cardiac death is. And that was shown by one of the American groups. Next slide. However, there are some problems with this data. So what we know is that data hasn't been reproduced in lots of other studies. There is a bias to some of these studies. So they're done out of major centers where they often get the sickest patients, or MRIs are often requested in the patients that you're most worried about. The methods used to quantify SCAR are largely variable in different hospitals. And nobody really knows what this adds to the existing way that we use risk stratification. So does having 20% SCAR confer more risk than what the risk calculator calculates for us? Nobody really knows. So although I think most of us acknowledge the role of SCAR and it does raise some concern for us, I think we have to use that in conjunction with the other ways we've got that have been formally validated of measuring risk, and that's primarily the risk calculator. Next paragraph. So what do the guidelines tell us? So the European guidelines, which I've shown here, clearly show that if your risk on the calculator is more than 6%, we should be offering our patients a defibrillator unless there's a reason not to. If the score is between 4 and 6% over 5 years, there's a good indication to at least have a discussion regarding the role of a defibrillator. And generally, if the risk is considered less than 4%, an ICD is something that we wouldn't routinely recommend unless there's something else that's pushing us to consider that. And that would be something like weakened heart muscle or a lot of SCAR on the MRI. Next slide. The Americans, however, have continued to stick to the risk factor model. So certainly the presence of one individual risk factor, such as a family history or having really significant hypertrophy, would lead to a recommendation for a defibrillator. And they also give some weighting to just having SCAR on the MRI and arrhythmia in isolation as an independent indication. So certainly the guidelines are probably a little bit more aggressive in terms of who gets offered a defibrillator. Next slide. But what does that translate to? So what we can see from when we look at large registry data, certainly on the left-hand side, the rates of ICD implantations in the US centers are twice that of non-US centers. And importantly, what we can see is that the rates of patients getting shocks when they need are much higher in the European cohort. And perhaps most importantly, in those that don't get defibrillators, the risk of experiencing a cardiac arrest or sudden cardiac death is the same. So it doesn't seem like the liberal ICD use is offering any additional protection. Next slide. Now, this is probably not a conversation that we'd be having if an ICD was like taking paracetamol, where there's probably not much in the way of side effects. But we know that ICDs themselves are not benign therapies, and some of you may have one or have had issues or complications relating to an ICD. So they're great treatments and they do save lives and they're very important, but they also come with their own baggage. So we certainly know that in patients that have ICDs, there's a risk of inappropriate shocks, getting shocks when you don't need. There's a risk of complications relating to the leads that patients have implanted, either they fail and they fracture and leading to shocks. There's risk of infections, either where the pocket of the ICD sits or more deep-seated infections, and which can often make people feel pretty unwell. So again, and the rates of these complications are not low. They're between 10 and 20% over the lifespan of a device, and that's really important. So when we're considering a decision for a defibrillator, as much as we have to consider the indications, we have to consider the risk of implanting a defibrillator. Next slide. Now, some of these risks are reduced by more recent ICD technology. So the transvenous ICD, which is the one that's in the middle, is the more traditional type of ICD that most people will be familiar with, where it's implanted in a similar way to a pacemaker. So we implant a lead through one of the veins at the top of the chest into the heart and connect it to a generator which sits in just underneath the collarbone. Now, that is the most tried and tested form of defibrillator, and it's the one that's in direct contact with the heart, allows you to use it as a pacemaker, senses the heart directly, so there's no inferences made, and it can deliver different types of therapy. So it can deliver a shock therapy if it needs to, and it can also deliver a pacing type of therapy for treatment of fast heart rhythms if it needed to, which is a more painless way of terminating heart rhythms. We've now got what we call the subcutaneous ICD and the EV ICD, which all sit outside the bloodstream. And the advantage being, therefore, is if there is a complication relating to the pacing lead or if there's an infection, it doesn't become systemic, and it's much easier for us to take the whole system out and treat people with antibiotics. Because the risk is, once an ICD has been in for a number of years, taking the leads out can become challenging and actually a risky procedure in itself. So the advantage of these subcutaneous and EV ICDs is that they allow us to implant and protect patients without running the long-term risk of having vascular complications or vascular complications that then become a difficult proposition to deal with. Next slide. But they all have their pros and cons. So as I mentioned, the transvenous ICD is the one that allows us to treat the heart rate, allows us to use it as a pacemaker and deliver pacing technologies for terminating arrhythmias. It's the one that's been around the longest. But as I said, the risks are, if something goes wrong with the lead or if a patient has an infection, removing and fixing the problem becomes much harder. The SICD is a technology which has probably been around just over a decade. And again, it's very effective at delivering shock therapies, but that's all it can do. It can't pace the heart and it can't use what we call ATP, which is the pacing technology to terminate arrhythmias. It also has far more limited diagnostics, so we don't get as much information about other heart rhythm disturbances. The battery life is not as long, and it's not suitable for all of our patients because it uses your surface ECG to determine whether you're a suitable candidate or not. And then the most recent device is the extravascular ICD, which is made by Medtronic, has it's probably a hybrid of the two systems. So it does allow us to deliver ATP, which is the pacing technology to terminate heart rhythm disturbances. The generators are smaller and they last a bit longer. However, it doesn't allow effective pacing, and it's the newest technology. So we still have some reservations about how it's going to play out over the next 10, 15, 20 years. Next slide. The data suggests that the SICD is as effective as at treating dangerous arrhythmias, and the risk of getting shocks when you don't need seem to be comparable between those with SICDs and transvenous, the traditional type of ICDs, and sit probably somewhere between 8 and 10%, which is still significant, but comparable. Next slide. And again, the EV ICD, the data remains quite limited on it, but what we do know is that the effectiveness of an EV ICD is roughly the same in patients with and without hypertrophic cardiomyopathy. So it seems to be a suitable treatment. The risks of inappropriate shock still remain pretty high. Maybe up to 1 in 5 patients in these small studies may experience shocks when they don't need. This is something that's getting better because the technology is improving, and the algorithms to determine sort of what needs treating and what doesn't need treating are improving all the time, as are our implant techniques. But it's still relatively early days for this technology. Next slide. So in summary, next slide. Anticoagulate anyone with atrial fibrillation. Next paragraph. Next slide, sorry. When somebody develops an ejection fraction of 50%, which we'd consider normal for most patients, this is a sign. This is a bad sign in patients with hypertrophic cardiomyopathy. An ejection fraction of 50% is a time where we should really start to focus on optimizing care to improve cardiac function, because 50% is abnormal in patients with hypertrophic cardiomyopathy. Next slide. ICD decisions really should be individualized, and ultimately a concept of shared decision making is really, really important. And that varies for individual patients. Some people want to know more, some people want to know less, but really explaining to an individual what their risk is made up of, and the options they have is really, really important, because ultimately the patients are the ones that are going to live with the decision. Next slide. And there is no perfect ICD. And again, it's finding the right one for the right patient based upon their needs and their wishes. Thank you. And I will pass on to Jodie to talk about genetics.
Awesome. Thanks, Vimal. And I think everyone would also agree. Huge thanks to Lee for facilitating this whole thing. We're all extremely lucky to have her be able to put these events together. So I might be biased, but I think I get the most interesting topic to talk about. So I'm going to be talking a little bit about the genetics of hypertrophic cardiomyopathy. And as Lee mentioned previously, I'm a genetic counsellor. So I have been talking to patients like some of you guys and like some of the genetic counsellors on the call for a really long time. And often I'll say to people, don't worry if you don't understand it all at once. Sometimes it's a bit like a science lesson, which maybe people weren't completely prepared when they walked in the door when we have these discussions. So I'm going to go through it all fairly high level, but feel free to stick questions in. So hypertrophic cardiomyopathy is actually quite an interesting condition genetically. One of our PhD students, Sophie Hesp, recently went through all of the genes that have been previously reported to cause hypertrophic cardiomyopathy, including new ones. And we went through this process of curating, so looking up the evidence and figuring out if these are actually associated with hypertrophic cardiomyopathy or not. And the interesting thing was we used to kind of talk about hypertrophic cardiomyopathy as a disease of the genes that encode the cardiac sarcomere. So the sarcomere in the heart cell is basically like the little engine. It's like the contractile unit of the heart. But now actually we know that lots of other types of genes can actually lead to left ventricular hypertrophy, which can sometimes look a lot like hypertrophic cardiomyopathy. Oh, next slide. I can't progress them. That's right. So what is genetic testing? Genetic testing is a process of looking for an underlying genetic cause of a heart condition. It can be really useful in clarifying a person's diagnosis. So even though on the clinical test we might say that you have hypertrophic cardiomyopathy, Genetic testing can help us confirm that, or it can help pick up some of these other conditions that can look like hypertrophic cardiomyopathy. In some cases, increasingly, it can be useful in letting the cardiologist know how they can better look after you. Really importantly, it helps us understand the risk for your family members who are also at risk. It can provide some additional reproductive options. And I've put this in, and I haven't included this much until the last year or so, but in future, this is going to be a first step for a lot of targeted therapies. So without a genetic diagnosis, it'll be a lot harder for people to access some of these newer therapies that come online. So accessing genetic testing usually involves going to a genetic service or a specialized cardiac genetic clinic. It's really different depending on where you live in Australia or in New Zealand. So I won't go into the specifics a bit too much. But in Australia, we now have genomic testing covered as a Medicare under the Medicare benefit schedule. So that means that all patients should be able to access cardiomyopathy genetic testing at no cost. Getting in to see a genetic counsellor can be slightly trickier. And this is something we're very aware of. And our group, for one, are looking at different ways of being able to develop more scalable methods for doing this. I guess if this is something that you're really having trouble with, that would absolutely be something to get in touch with Cardiomyopathy Australia, New Zealand about who can kind of help direct you. Next slide. Okay, so this is going to be a quick overview of what we actually mean when we say genetic testing. So essentially, it's a two-step process. The first step is we identify someone in the family who definitely has disease, often what we call the index case. So someone with, really apparent clinical disease. That's indicated in this figure. I'm not sure if you can see the cursor. You probably can't because I'm not showing my screen. By the plus. And that's the person we take a blood sample for. That sample will go to a clinical laboratory for genetic testing. If you just go to the next slide. And basically what this process is looking for is it's sequencing through all of the genes that we know that can, a change in one of those genes can cause a cardiomyopathy. And so if this is from a figure that one of our PhD students previously made for a communication booklet. But basically, if you think about the DNA code as a series of letters, what the lab are looking for are changes in that DNA code that deviate from a reference sequence that we have. What we've learned over the last 10 years or so is that changes in our DNA code are really common. So everyone has lots of rare changes in their DNA. So figuring out which of those alterations to the DNA code is causing disease and which is just there by chance and just makes you a little bit different to everyone else is probably technically the trickiest part of genetic testing. We go through a whole bunch of criteria. I won't bore you with any of that detail, but it's kind of like detective work. We're building up a case, looking for evidence to support whether this particular change to the DNA code or variant or mutation, as we used to call it, is actually causing disease. If there's enough evidence, we would call that particular variant likely pathogenic or pathogenic. If there's enough evidence to say this is not the cause of disease, this is just something that exists in the population and doesn't do anything, then it would be called benign or likely benign, and the lab won't usually put that on a report. And some of you have probably heard about a variant of uncertain significance. That's something that sits in that middle grey area and basically means we can't resolve whether it is or isn't the cause of disease. Next slide. So when we do that type of diagnostic or index genetic testing, there's usually three possible outcomes that we really want to make sure you understand when we send that testing off. One is we find a result that explains your heart condition, and that's really useful. As Andris has already said, that's about 40% of the time. The other option is we do that testing and we don't identify any genetic causes at all. That's an inconclusive result, and I'll talk a little bit about that in a minute. Or we do the testing and we find a variant, but we can't say with certainty if it is or isn't the cause, and so we call that an uncertain variant, and that's a little bit annoying, but we can deal with that. Next slide. So if you get a positive result, this is obviously useful because it means we've got an explanation for your heart condition, but what does that mean for your family? This is really probably one of the most important reasons for genetic testing, because if we know what's causing your heart condition, we can then look to see if other at-risk relatives in your family do or don't carry that same genetic variant. So, for example, if you have a healthy relative who is shown to have that same genetic variant as you do, that doesn't mean they have hypertrophic cardiomyopathy, because you only have hypertrophic cardiomyopathy if your cardiologist, sees that on echocardiogram and says that you have it. But it does mean that you could be at risk of developing it in future. And so they're the sorts of relatives that we would suggest continue to see their cardiologist into the future every few years, according to the screening guidance. We also then know that that individual, if they have children, their children have a 50% risk of having inherited that as well. So it allows you to cascade through the family and identify those who need to be seeing a cardiologist. If, for example, a relative is shown not to carry that genetic variant, this is the really great genetic results that we like to give out, because it means they're not going to develop hypertrophic cardiomyopathy, and their kids can't inherit something that they don't carry. So that's a really useful result. Next slide. And there's different cardiac screening advice based around those genetic results, or for family members where there's no genetic result available at all. And these are best to talk about with your cardiologist, but usually the younger a family member is, so sort of in that teenage years when things are most likely to develop, that's when there's usually more frequent cardiac screening. And as you get older, that the period between screening can increase, and that can become less frequent. So what does an inconclusive result mean for, remember going back to the index case, if we don't find any cause for hypertrophic cardiomyopathy, what does that actually mean? Okay, so this is kind of common. It's probably about 40 to 50% of the people we test who have a diagnosis of hypertrophic cardiomyopathy. We don't actually identify a genetic cause for that. And actually, we're starting to understand that some of those patients just probably don't have an inherited form of the disease. The interesting thing is, if you pick up any research paper, it'll tell you that all hypertrophic cardiomyopathy is inherited. And I think the biggest thing to happen over the last 5 to 10 years is we're definitely understanding that that's probably not true. But we don't know exactly who definitely doesn't have doesn't have an inherited form. So it's really hard to, give guidance to family members if we're not completely sure. So at the moment, we still are on the side of caution and suggest that people still, consider this an inherited cause. But we're learning that it's probably combinations of genetic, small genetic changes, in addition to probably some, environmental things like high blood pressure that just come together to create a situation in the heart where it looks like you have the same condition as something caused by a single genetic change. It's kind of complicated, but at the moment, we just don't expect that every patient will have a genetic variant identified. Saying that, there's definitely gaps in our knowledge. So we have some kind of red flags. If you have genetic testing and no variants are identified, but you have indicators that suggest you have something being inherited in your family, like a positive family history, so other relatives in the family with the same condition, and also severe disease. So things like people having ventricular arrhythmias or heart transplants, like the sort of more severe end of the spectrum. We don't really accept that that hypertrophic cardiomyopathy isn't inherited in those situations, and that's when research can be really useful because we can look instead of just at those handful of genes that we know and understand really well. Research means we can look much more broadly, and we run a study called Elusive Hearts where we're actually able to do that, and we've been finding lots of new things that will eventually form part of the clinical testing that all hypertrophic cardiomyopathy patients will have. Next slide. I know we're slightly over time and there's not much more to go, so just useful if you can hang on. So if and when to retest, I noticed this was a question that we got earlier on. I think the other thing that's really changed over the last few years in our field is that genetic testing isn't necessarily a one-off test anymore. Like I've said before, our knowledge and the research that we're doing is moves pretty quick, and we're finding lots of new things. And what that means for the people who've already had genetic testing is that we probably need to be re-looking at that at some, frequency over time. If you've got an answer, then that probably doesn't impact on you because you've probably got an answer and probably not much is going to change that. But if you had inconclusive testing or an uncertain variant identified, then potentially retesting, if the testing was done more than 5 years ago, isn't a bad thing to do. This is something that our health system is absolutely not capable of dealing with. But again, if you've got a positive family history or anything like that to indicate that there's probably an inherited cause and your testing was done a while ago and no answer was found, that's probably something that would be worth revisiting. Next slide. Okay, gene therapy. This is the question that a lot of people have, and it's something that we're all learning a lot about. So next slide. There's a few different types of gene therapies. So gene therapies basically can correct the underlying genetic cause for your disease. Where we're at the moment in hypertrophic cardiomyopathy and other inherited cardiomyopathies is gene replacement therapy. So we know that some of these conditions, some people's disease is caused by a genetic variant in a particular gene that means that less than the normal amount of protein is made. And so you can actually fix that by giving a gene therapy that creates more of that normal protein. And that actually can, reverse disease in lots of different disease contexts, not even just hypertrophic cardiomyopathy. These are all really early stage at the moment. There are early clinical trials going on. They're mostly dosing, like looking for early responses. Lots of challenges with gene therapy. One is the vector that's used to deliver it. A lot of people naturally have antibodies to that, so you can't actually have the gene therapy. And the other thing is once you've had one shot of the gene therapy, you're then done because you've got an immune system that won't allow that vector again. So there are lots of challenges. We are thinking about this really carefully in Australia. We know a lot of people with hypertrophic cardiomyopathy, might have symptoms, but aren't necessarily limited in their lifespan. So at the moment, while things are a little bit up in the air as to how safe these things are, it's a bit difficult in hypertrophic cardiomyopathy to know, when you're potentially imposing more harm than benefit. So lots to come on that. But the main thing we're thinking about at the moment is we need more families to have a genetic diagnosis before we even get to this point of thinking about effective therapies. Next slide. One of the things we're doing is we have a national registry because if and when these types of therapies or other research becomes available, we'd love to be able to let people know and find where people are in the country. And so if this is something that people are interested in, or if you're a clinician and you're happy to give out brochures in your clinics, Any patients with inherited cardiomyopathies can join this. It's a fairly simple consent form, and we can keep you updated on things. And if you've got questions around the genetic testing side of things as well, you're also very welcome to email our team. We've got lots of research genetic counsellors in the team who can often answer questions about genetic testing. I think that might be it. Laura very nicely made these slides, so she knows what's coming better than I do. I'll hand back over to Lee, though.
Thank you very much, Jodie. And yes, we are over time. Thanks everyone for sticking with us, which it does mean we're going to skip over this Q&A session so folk can get on with their day. So if you do have questions, please pop them in the survey that's going to be coming around. It's there burning, and we will get those answered for you. Just a couple of closing comments. I just wanted to say we've spoken a lot today about some of the more serious complications or the more severe spectrum of hypertrophic cardiomyopathy, but we know that it's a spectrum disease and very few people will go on to have some of the things that we've spoken about today. So I just wanted to make that point. Within my own family, which is a big family, over 10 people were identified when we did our gene testing way back in the 90s, many more born since, and I'm the only transplant, and we have only 3 others, me and 2 others with defibrillators. So you know, even within the one family, it's a variable disease. So I wouldn't want anyone to leave with the impression that because we've spoken about it today, that's something that will be your story. Your story is your story, and these are tiny numbers that we've been that would eventually progress to the things that we've spoken about today. But they're the scary things, and they're the things people want information on. So hence we've talked about them. Another comment is mavacamten, which was spoken about, unfortunately is not yet approved and available in New Zealand. Just to say that, and we're building our advocacy case to have the patient voice quite strong should it be brought for approval and funding in New Zealand. So if you're a New Zealander on the call and interested in joining in with that, please keep in touch with me. The address is on the website, info@cmanz.org.au. I've spoken about the recording will come with the feedback survey. And I certainly learned as part of this that we could have probably had a webinar on each of these sessions, one on anatomy, one on the treatments and complications, another full webinar on genetics. So we'll look at building our resource library and running more podcasts or webinars to dive more deeply into some of these big issues. So I want to thank very much the Garvin for being co-hosts and this partnership, Laura Cato from the Garvin, who has put together all of the logistics related to this, which was no small feat. Thank you very much to Andris, to Vimal, and to Jodie for coming along and speaking, and thank you to you all for being here. And we look forward to keeping in touch. So join up to our newsletter via the website, and we'll be see you at a webinar in the future.